Good morning, everyone. My topic for today is flapless external DCR. Is it time to say goodbye, flaps? I have no financial relationship to declare. Personal communication with many ophthalmologists revealed that failure of the procedure and tedious flap making in DCR are the main cause of reluctance from this surgery. As a result, DCR is ignored by many eye surgeons and lacrimal surgery is increasingly being undertaken by ENT surgeons, particularly in peripheral areas. In an era when other specialties are always looking to widen their surgical spectrum, we must not lose these patients. To overcome the problem, I started a no flap technique in DCR, which is less time consuming, easy to perform, result at par. Total number of the patients in this study are 2768 and period was from March 2011 to March 2019. Inclusion exclusion criteria and preoperative management are same as any DCR surgery. Curvilinear scan incision was made 2 to 3 mm away from the medial canthi. Medial 1/3/4 of the sac and upper portion of the nasolacrimal duct are removed so that the lateral part of the sac remains as a disc with punctum in its middle, similar to Toti's DCR. A is lateral 1/4 of the lacrimal sac. B is the tip of the Bowman's probe coming out of the common canaliculi. Lateral 1/4 of the lacrimal sac remained as a disc with punctum in its middle, like a funnel. 10 mm Aruga's bone trephine was used to make ostium in lacrimal bone and passage in the nasal mucosa, and it is Aruga's bone trephine. This one is the Aruga's bone trephine with nasal mucosa and bone, and this is ostium in nasal bone. Anterior lateral part of the lacrimal sac was sutured with subcutaneous tissue of the medial side, adjacent to the newly formed ostium with 60 vicryl or silk thread, medial palpebral ligament, and rest of the incision is sutured. On a fifth postoperative day, sac syringing with 1 ml of 0.4 milligram per ml mitomycin was done in newly formed passage and near bone ostium. No major complication was found during surgery or in follow-up. Changes I made was medial part of the lacrimal sac was removed. Aruga's bone trephine was used to make ostium in nasal bone adjacent to lacrimal sac and nasal mucosa. Mitomycin C was used on fifth postoperative day for syringing in the newly formed passage near ostium and nasal mucosa. The patient were followed up for 1 year. Functional success was defined as an absence of tearing, assessed using Monk score. EP4 of grade 0 to 1 are known as considered as successful. Anatomical success was defined as patent with no significant reflux on syringing. Ostium size changes measured on 7 day, 15 day, 1 month, 2 months, 3 months, 6 months, and 1 year by the nasal endoscope. This one is the nasal endoscopy at the end of 1 year, and that is ostium in nasal mucosa and bone. Endoscopic view after 7 days, 15 days, 1 month, 3 months, 6 months, and 1 year. Ostium size shrinkage was marked in the first 3 months. After that, it is nearly stable and found 4 to 5 mm oval or round in shape at 1 year. And results were analyzed after end of the study, and 2732, that is 98.66% patients were successful at the end of mean follow-up period, that is 12 months. 16 patients complained of epiphora of grade 2 or more and sticky eye despite successful syringing. 20 patients failed in syringing during the follow-up period due to closure at osteotomy site. Thus, in our study, anatomical or objective success is 2748 patients, that is 99.2%. 99.27%, and functional or subjective success is 2732, that is 98.66%. I have obtained the idea of doing flapless external DCR in accordance with the endonasal DCR, which has a high success rate without flaps. So the procedure of external DCR is designed to be done with neither anterior nor posterior flaps. I observed that the osteotomy done without flaps has a much less incidence of adhesion and synechia that may lead to failure of the DCR. Because of the known antifibroblastic properties, mitomycin C was used here, and it was found that the safest and most effective dose of mitomycin C is somewhere between 0.2 milligram to 0.4 milligram per ml. That's why in this study, 0.4 milligram per ml mitomycin is used for syringing. In the present study, syringing of 0.4 milligram per ml mitomycin in the newly formed lacrimal passage on the 5th postoperative day decreased the incidence of postoperative adhesion more significantly because it is not diluted by the bleeding from nasal mucosa and better coincides to early proliferative phase, which starts from 3rd to 5th day of the tissue injury. That is the stage of fibroblast migration and proliferation in the wound. The success rate in this study was 98.6%. And despite the large sample size of that is 2,768 patients, and the success rate among published research varies from 70% to 100%, and the sample size of these studies published as yet ranged from 19 to 176. The success rate of this study is significantly better than the previously published reports due to the large sample size of the current study. So I conclude that the flapless DCR method is easy to perform with reliable comparative result and less cumbersome. I know my method is not for them, but it is boon for these masses. Thanks to my co-author and speakers, and thank you. Thanks.
Sir, any questions?
Dr. Ravi Ranjan ji,
Sir.
I ask a question.
Yes, sir.
So you have not made the flap, and most of the surgeons are making flap. So is there any advantage of making flap, or there is no advantage of making flap?
There is advantage of making flaps, sir. I have shown clearly in my slides. It is less cumbersome and adhesion is less. And that's why failure.
I am not asking this thing. I am asking those person who are making the flap. So is there any advantage of making flap over this without making flap in DCR surgery?
I don't think so, sir. Not advantage.
Okay.
Dr. Javed?
Yeah, see, this flapless things have been happening for a long time now. And the recent paper that I remember is from Abdullah Mujani from Oman, who has published large data of these things. So while everybody has their ways of dealing with that, and as long as their patients are happy, I don't think any one of us should have a problem with that one. But I would always preserve lacrimal sacs. And the presumption that endoscopic DCRs don't preserve lacrimal sac is wrong, because in endoscopic DCRs, you create a mucosa to mucosa approximation. Okay, as opposed to an external area where you may have to use some kind of a suture. So the very fact that Dr. Ranjan is also using the anterolateral wall to suture to the subcutaneous tissue, it just means to me that the flap is still there, at least the anterior flap is still there. And loss of posterior flaps anyways in randomized control trials, very large one, does not anyway cause any problem if you do not retain the posterior flaps. So he's still using a little bit of anterior flaps, maybe to the subcutaneous tissue, and that might be helping him.
Dr. Savita, do you want to make some comments? Flapless?
See, the thing is the flapless DCR, there is a difference in the type of healing. So unless, again, without a flap, I don't know how the results can be so good. And when you are opening up the whole thing, you're making an incision. So why not make flaps? I mean, it's hardly cumbersome. You have opened up the sac, you've opened up the bone and the nasal mucosa, everything. All you've got to do is just pick up the flaps and suture them. I don't see how it makes the surgery less cumbersome. Because with flaps, with suturing, especially in external DCR, the healing is by primary intention, and in your way, this is a secondary intention healing. Okay, so this cannot be a better method. According, this is my opinion. This is what I think.
Madam, it is healing by primary intention, first intention. I have consulted many pathologists, GI surgeons, maxillofacial surgeons, because
Mama, now you continue. I'll pray from here only.
Thank you.
You can carry on, Dr. Ravi.
Well, we are short of time. Thank you, Dr.